Okay, we're fast forwarding in your book. All right, we're going to page 931. Going to talk about GERD, gastroesophageal reflux disease. You have a bad lower esophageal sphincter, and it allows contents to back up. And this is bad because it can lead to esophagitis, which is inflammation of the esophagus. But if it happens enough over time, you can actually develop what's called a Barrett's esophagus. You actually have changes in your cells, can be considered precancerous. And so that's why we need to get a handle on this. So, when someone has GERD, they're going to tell you, they have heartburn, especially after meals. They get that sour material back in their mouth. They can have difficulty swallowing, chest pain, belching. And so those are some of the signs and symptoms. Factors that are actually associated with the development of GERD are found on the top of page 932. You can read through those. So we're going to diagnose someone with GERD. Then we can do a barium swallow. Often, though, this person gets what we call an upper endoscopy, EGD. A lot of times you'll hear it called an EGD. And they go down, take a look in the esophagus, possibly biopsy it, also take a look in the stomach. And then you can also have a 24-hour pH test. So when we are going to treat someone that has GERD, we often put them on medications. So go ahead and flip to page 934, grab a highlighter, okay? And then on 934, the drug therapy table, the first ones that are listed are the PPIs. You guys are very familiar with the PPIs. You can see that they end in Zole, Z-O-L-E, right? We take these typically one time a day. They decrease the hydrochloric acid secretion by inhibiting the proton pump. And few side effects: headache, abdominal pain, nausea, diarrhea. The big thing now is we realize that these are increasing the risk of fractures. So we know that the PPIs are increasing the risk of fractures, and we have to watch this carefully. Your H2 receptor blockers, you can see that they end in DINE, D-I-N-E. These are older. These guys block the secretion of histamine receptors, therefore decreasing the hydrochloric acid. These guys can actually be taken a couple of times a day, so they can be taken in the morning and at bedtime. Minimal headache, abdominal pain, constipation, diarrhea side effects. They do have to be taken 1 to 2 hours before antacids, though. We get down to the prokinetic agents, and we get to Reglan. And Reglan, all it does is actually increase gastric motility, so it increases how fast the stomach empties, and that helps to move the food through quickly and empty it and reduce reflux. You can actually have some bad CNS side effects, so you have to make sure we monitor for those, and EPS, or extrapyramidal side effects, such as tremor, dyskinesias like we see in Parkinson's. You can have what we call anti-nuclear protectants, such as sulcrafate, which is carafate. These guys actually form a protective layer. They serve as a barrier against the stomach. If someone suffers from esophagitis, these often are given for a period of time. And then you guys can actually read through your antacids, okay? If you look at the bottom there on page 934, there is a drug alert for PPI, and it's just once again reminding us about the risk of fractures, okay? And that PPI is associated with an increased risk of C. diff and hospitalized patients. So those are the drugs that we can use. When we look at lifestyle modifications, if you guys just look at page 933, the patient caregiver guide, you can read through these, and this is where we will pick up in class. We will talk about the Nissan fundoplication in class. It can be done laparoscopically or open. It's pretty clear you guys can see that they're actually just taking a portion of the stomach and taking it and anchoring it around the esophagus. and it is to stop that lower esophageal sphincter from giving in and allowing the reflux of contents into the esophagus. And so this is only done for patients that have not done well with lifestyle modifications and with drug therapy. Okay, so the esophagus is actually used to reinforce the sphincter. A hiatal hernia is just where a small portion of the stomach has been allowed to slip through the esophageal hiatus of the diaphragm. And so these guys, you can see the hiatal hernia, and these guys often have very similar signs and symptoms to someone who is suffering from GERD. Diagnosed the same way as GERD, and what we do here is that we encourage these people to eat small, frequent meals, to not have any spicy foods at nighttime, elevate the head of their bed. Sometimes at home, this means that they have to actually raise the head of the bed on blocks, to take their antacids a couple of times a day, to do anything that could reduce the intra-abdominal pressure. So, for instance, don't bend over right after you eat, don't wear tight clothing around the abdomen, don't go to the gym and lift weights after you eat, those types of things. If lifestyle modification and drug therapy does not help with the hiatal hernia, you can actually have surgery, and the surgery is the same as for GERD. It's the Nissen fundoplication procedure. Okay, next, peptic ulcer disease. This starts on page 942, guys. All right, great picture of an ulceration in the duodenum. And so you can get an ulceration, which is just a break in the mucosa, anywhere in the GI system. It just happens to be that the duodenum is the most common, but you can certainly get them in the esophagus and the stomach. They can be acute. Acute tends to be a more superficial ulceration, resolves quickly, versus chronic seems to be deeper, more involved ulceration of the mucosa. H. pylori is actually a bacteria that can be found in the majority of the population, and in some individuals it actually leads to peptic ulcer disease. And so when we are exploring why someone has peptic ulcer disease, they are always tested to see if they have H. pylori. Other factors that are associated with the development of PUD are meds. Certain meds, such as, we know NSAIDs and steroids can cause peptic ulcer disease. Certainly lifestyle, a diet that's high in caffeinated beverages like coffee, alcohol consumption, certainly lifestyle issues such as a lot of stress can lead to, and smoking actually delays healing of the ulcers. And those are some of the risk factors associated. We're concerned with peptic ulcer disease because it can lead to a hemorrhage where it erodes enough into the mucosa that it exposes the vessel and it actually hemorrhages. It can also then lead to perforation if it erodes full enough, and it can lead to obstruction. The signs and symptoms, I want you guys to be clear on this, the signs and symptoms that someone will experience when they have peptic ulcer disease obviously vary according to where the ulceration has occurred. So we're looking at page 944, okay? And for instance, if we have someone who has an ulceration that is a gastric ulcer and it's high in the stomach, typically they have issues 1 to 2 hours after they eat. The pain is described as burning or gaseous. And if the ulcer has eroded through the gastric mucosa, food tends to aggravate it rather than help it. Okay? Now, if someone has a duodenal ulcer, all right, then when they ingest food, it helps to provide a buffer. And generally, people develop signs and symptoms 2 to 5 hours after they eat. And the pain is often described as burning or cramp-liking. Okay? And so you just have to realize that where the pain is and the signs and symptoms they have is dependent upon where the ulceration is actually located. Okay? When someone is diagnosed with a gastric ulcer, we can do so gold standard really is an EGD. Okay, so go in, take a look, where's the ulcer, biopsy it, make sure there's no cancer cells, get a piece of tissue. We can look to see if the patient has H. pylori. So one way you can diagnose H. pylori is to actually do so with the biopsy. You can also do blood testing for H. pylori. Okay. Are we concerned that they're anemic? Have they been bleeding? What is their CBC, specifically their H and H? How do we treat them? Meds, as we've already talked about. You're going to put these people on a PPI. Listen, it's good if we can take them off of, let's say they're on an aspirin or an NSAID. It's great if we could take them off for a few weeks. If not, let's say that they must stay on their aspirin because they have like a cardiovascular risk. Then we want them to, 1, switch to an enteric-coated aspirin, and 2, take their aspirin with a PPI. Okay? Now, if someone is diagnosed with H. pylori, then they must be on a PPI along with an antibiotic therapy for a few weeks. Okay? Now, there is a difference in acute versus long-term treatment. If someone comes in, they have a gastric ulcer, and it's bleeding, then obviously we're going to make them MPO, possibly do gastric lavage. And gastric lavage just means that we're putting in an NG and irrigating their stomach with cold fluids, such as normal saline, to cause constriction and slow the bleeding. Then we would slowly reintroduce fluids and food. The thing with peptic ulcer disease, there is no specific recommended dietary modifications. Patients must just keep track of what upsets their stomach and stay away from it and what's good, okay? Again, peptic ulcer, we've already talked about how we would diagnose it. We've talked about H. pylori. We've talked about meds. We'll talk about the different types of surgeries that might be required, but they're rare, okay? So we'll talk about the partial gastrectomy, the vagotomy, the pyloroplasty, and the Bill-Roth 1 and 2 in class. I do want to point out on page 949, there is a great patient caregiver teaching guide for someone who has peptic ulcer disease, and I want you guys to review that. Again, we'll talk about these different types of surgeries, the Bill-Roth 1 and 2, in class. And we will talk about the post-surgical care of a patient who's had to have surgery because of peptic ulcer disease. So we'll finish up this lecture in class, guys.